In this talk, we're going to discuss psychiatric diagnosis, an issue that's already come up at several points in our discussions of neuroethics. It arose in discussing PTSD, the question of who is eligible for treatment, who's eligible for disability status, and so forth. It came up talking about depression and sadness, and whether grief at the loss of a close loved one should be labeled as major depression, which is a psychiatric disorder, as opposed to just a painful part of normal life. And it comes up with the question of whether a physician like Anjan is treating somebody or enhancing somebody if he gives them stimulants because they come to him saying, you know, I have trouble paying attention for the long periods that I need to, you know, in my busy life. Well, is he eligible for a diagnosis of ADHD? Well, you know, what does it mean to diagnose ADHD? Where do these criteria come from, et cetera. So today we're going to approach this issue of diagnosis from the point of view of asking whether psychiatric disorders are kind of distinctive, coherent types of brain dysfunction that can be seen on functional brain images, functional or structural brain images, and therefore whether the proper way to diagnose psychiatric disorders would be to use brain imaging. Are we just being Luddites to persist in these current DSM type criteria? Well, whoops, why am I not? Oh, I know why I'm not. There we go. So here's a quote by somebody we'll talk more about in a moment. Daniel Amen, he's a psychiatrist who uses SPECT imaging, a type of functional neuroimaging, for psychiatric diagnosis. He says, psychiatrists continue to make diagnoses the same way they did 100 years ago, based on clinical exams and symptom clusters. There is a better way, he says. SPECT imaging is a clinically useful way to look at brain function. Contrast that with a recent consensus report of the American Psychiatric Association. They are the people that write the DSM, saying there are currently no brain imaging biomarkers that are currently clinically useful for any diagnostic category in psychiatry. So a rather sweeping statement, although very, qualified by saying currently. In fact, they say currently twice. Okay, so these authors are not saying, and there never will be, but they are saying right now it is not useful. So we have quite a kind of bald difference of opinion there, and that is the difference of opinion that we are going to explore and decide essentially who's right and why. So here are the questions that we're going to ask. First of all, what's at stake in this controversy? We're going to consider the medical and the societal benefits of having a good imaging biomarker as a diagnostic test. Next question, why would you expect brain imaging to be diagnostic? And I've kind of already alluded to the answer to that, namely, if you think psychiatric disorders are brain disorders, then why don't you image the brain? That's the challenge from the pro-imaging camp. Then we're going to consider why, in fact, it probably isn't diagnostic currently, as those APA authors hasten to add. Finally, we'll end with the question of whether there's reason for optimism. We'll look to the future and see what we might expect, coming down the road, maybe DSM 6 or 7. Okay, before we go on though and start with number 1, I want to introduce question number 0, which is why call this an ethical issue? this seems like a clinical practice issue? Well, there are a few reasons. First, there's obviously high risk of harm to patients if they're treated based on the results of invalid tests. Okay, if you get the wrong diagnosis because you're using a bad diagnostic test, that's not good for patients, obviously. More generally, if we use kind of a broad definition of ethics, which isn't just about, doctor harms patient bad, but is more what the NIH has called ELSIs, ethical, legal, societal implications of a particular diagnostic test, then we'll see, as we go forward in this slide deck, that the question of diagnostic brain imaging is enmeshed in a whole network of ethical issues that includes how lay people, as well as scientists and clinicians, think about technology, think about brain imaging in particular, think about illness, stigma, and so forth. So I mentioned and quoted Daniel Amen in my earlier slide. There he is. He is a very successful psychiatrist. He has a number of private clinics where he treats people for psychiatric disorders and actually increasingly practices what you would call enhancement. That is sort of, lifestyle, health factors, tune up, you don't have to be depressed to want to feel better. You don't have to have marital problems to want to improve your relationship and so forth. And he offers help with all of these problems. In addition to the sort of traditional diagnostic tests, physician interviews patient, patient fills out various kinds of diagnostic, surveys, checklists. He also carries out brain imaging using SPECT, which is fairly old-fashioned, but for certain purposes, quite useful, suitable, kind of functional brain imaging. It's single photon emission computed tomography, I believe. Okay. He also is a television personality. He has specials that he produces and then donates to PBS to be shown, Public Broadcasting Service, public TV in the US, that get shown during pledge drives, and they show him, giving people advice for aging well and having good relationships and that sort of thing. Okay, so what is at stake? Why shouldn't he be scanning people to help with their diagnosis? Well, it turns out a huge amount is at stake. Whoopsie, I'm a victim of overly fancy PowerPoint here. Okay, the first thing is patient care. And this just goes back to what I said earlier. Giving the patient the proper care depends on getting the proper diagnosis, and that's, it has certainly not been proven that this sort of SPECT imaging improves the accuracy of diagnosis. Research progress. Well, consider this. Research progress in psychiatry is crucially dependent on correctly diagnosing the research subjects. So if you have a trial of a new antidepressant and you have enrolled patients who are not depressed but have some other problem, have an anxiety disorder or ADHD or you name it, you are not going to get the correct answer, the answer you're looking for from your research. I mean, I hasten to add that some antidepressant medications are useful for anxiety disorders and other conditions, but the more general point is, it's a kind of a garbage in, garbage out point, right? Your clinical trial is going to only be as useful as the way in which you've classified and screened your subjects. Ultimately, our whole understanding of what psychiatric disorders are is also at stake. Nosology is a fancy term for the system of categories or dimensions along which healthy and unhealthy people vary. It's basically our disease categories. And your ability to carve up the reality of psychiatric illness into the proper categories is going to depend on your criteria for diagnosing. I mean, it's kind of obvious, but it is important to notice that that there's a kind of reciprocal relation between, on the one hand, the nosology that we have is going to have implications for how we test for disease. But the way we test for disease is going to shape the nosology that we have. Okay. Another thing that's at stake here is patients' self-understanding and the understanding that families have of their loved ones who have a disorder. There's a belief that if you can see on a brain scan, or even some less beautiful, appealing, impressive biomarker, but if you can come up with an actual biomarker for a mental illness, that should relieve the person with that illness of some stigma. Then it's not a moral failing, then it's not, they should just try harder. It really is, they're sick. There's no more shame in having bipolar disorder, if you can show it on a brain image, the reasoning goes, than in having diabetes or any number of familiar physical conditions. In fact, the Amen website lists this as one of the benefits of using scanning. And he might be right about that. I mean, even that, I think, is an empirical claim. We don't actually know whether feelings of stigma are increased or decreased, if you can show the image on a brain scan. Carl Elliott wrote about an interesting case of a patient who was severely depressed and always kind of felt like it was just, she was a bad person, she ought to pull herself out of it, but she couldn't. And her initial reaction on being shown that it is a physical problem was, oh, thank heaven, it's not me, it's my brain, I'm not to blame. And then a little while later, she realized, oh, drat, I have a defective brain, So being kind of damaged goods isn't necessarily better for your self-esteem or for your acceptance in society. I think this is an area that could stand some research, but it is an interesting point, and according to Amen, you can help patients to feel better about themselves and actually elicit more compliance with treatment if you show them that there is a physical reason here. Look, it's in your brain. Okay, legal issues. I mean, for one thing, we already talked about the power of brain images in the courtroom. The judge in Brian Dugan's trial would not let Kent Keel even show a functional brain image because he thought the jury would just be overwhelmed and, convinced beyond the actual, import or information from that evidence. Well, Amen. And I should say other clinics too. There are a handful of other companies that offer these very similar services. Most of them have trained with Amen. This is a selling point of these clinics, that if you are going to be on trial for something, if you've been arrested for something, you can sort of try to get the understanding of the judge or the jury that it really was not so much in your control, because look, there it is in your brain made you do it. It could also have, I think, a very positive role to play in the fight for mental health parity. We still do not have complete parity for the coverage by insurance of mental health problems. They're not covered as fully as physical health problems by insurance. And to the extent that you can introduce evidence that, look, here's why you should pay for the treatment of this patient's diabetes. Here's their blood sugar reading lab test, and here's why you should pay for this patient's psychotherapy. Here's their brain scan showing their depressed pattern. Then you can sort of challenge in the courts, if not simply motivate legislators to say, look, there's no difference between these cases. You need to, if you're going to cover people for physical ailments, you have to cover them for all. Okay, what about the reasons to expect brain imaging to be diagnostic? Why does Daniel Amen and his type, his colleagues who agree with him on the role of SPECT imaging, what makes them so convinced? And what makes, I think, all of us think in principle, yeah, it sounds like a good idea, brain imaging for psychiatric diagnosis. Well, here we have, a few answers. One is that psychiatric disorders are brain disorders, right? I mean, that's basically the received wisdom now, and I think it's probably right. I mean, they're not kidney disorders, and if you're not a dualist, then you have to believe that they are brain disorders. So that certainly suggests that tests of brain function would be relevant. In fact, it's not just that in principle mental illnesses are brain disorders, so look to the brain. We actually know from mountains of published psychiatric research that psychiatric disorders, all of the sort of primary psychiatric disorders, show up in brain imaging. They show up, some of them in structural imaging, all of them in functional imaging. If you compare a schizophrenic person getting, fMRI of looking at emotional faces, or I would assume even a resting SPECT scan of function, to a normal person, they will look different. So, yeah, it's got correlates in brain imaging. In addition, sort of heaping on the reason to believe the brain is the place to look, many treatments, really most in this primary care driven system, are biological. People who are depressed get SSRIs from their primary care doctor. Or they may get, ECT or transcranial brain stimulation. These are all biological treatments. And even the behavioral treatments, talking therapy, cognitive behavioral therapy, alter the brain imaging correlates of the disease. So now we have brain imaging looking like a really good measure for a psychiatric illness. Person's depressed, their brain looks different from normal. You give them antidepressants or CBT. Their brain, the disease wanes, the disease remits, their brain abnormality remits. Why are we not looking at brain imaging to diagnose? Well, here is why. Okay, first of all, let's talk about features of brain imaging that explain why we're not using it for diagnosis. The first reason is, first reason is this mountain of literature that I referred to before, most of it has been done comparing groups of subjects with each other. Schizophrenic patients, normal subjects. But of course, when you're trying to diagnose a person, you're trying to diagnose an individual. Now, there is tremendous work being done, in part using the multivariate pattern analysis methods that Jeff Aguirre was telling you about, that is getting pretty good at separating individuals on the basis of brain imaging. And this is going to relate to our final question about should we be optimistic about the future. But right now, it's not the case that we can base a diagnostic protocol of imaging on some existing research that is going to tell us, how to interpret an individual's brain image diagnostically. The other thing is that for the vast majority of published brain imaging research in psychiatric patients, the contrast is a simple one between some disorder, X, schizophrenia, depression, ADHD, and healthy control subjects. But of course, when you go to the doctor, the question is not, am I sick with a particular illness or am I healthy? The question is which of a bunch of different illnesses, some of which look pretty similar phenotypically, which one do I have? And we just, again, don't have the evidentiary base of brain imaging studies comparing depression, unipolar depression, bipolar, schizoaffective disorder, ADHD, whatever, with one another. So we just don't know that right now. Another issue is that in functional brain imaging, most of the research, especially with fMRI, has been task-related, looking at task-related activations. So people are doing some task. They're doing an oddball task that stresses attention. They're doing a working memory task. They're doing a face detection task, and we're varying the facial expression that they're seeing. So you can't, it sounds very simple and natural to say, oh yeah, depressed people have hyperactive amygdalas, because there is a lot of very interesting research by Yvette Chalene and others showing that when a depressed person looks at a sad or angry face, a face with a negative facial expression, their amygdalas become much more active than the amygdalas of a normal, healthy person. But when we just say, oh yeah, amygdalas are hyperactive in depression, we're talking about in that particular paradigm. Other experiments use other paradigms that have nothing to do with faces. You would really need systematically to be able to compare brain responses to a common set of tasks, to be able to use those brain responses diagnostically to distinguish between tasks. It's just an issue of standardization, and it's kind of an obvious one, but I think too often the research gets summarized. Schizophrenics have underactive dorsolateral prefrontal cortices, or something like that, as opposed to really putting it in the context of the task, which is supposed to activate that part of the brain. And finally, as much as we all love brain imaging, it doesn't show us everything that's going on in the brain. It's limited in all kinds of ways. Every method for studying the brain is limited in all kinds of ways. You look through different windows and you see different things. There is no guarantee that brain imaging is going to capture the relevant pathology that causes these disorders. So really, it might. This research literature showing these seemingly systematic relations suggests that it probably will, but no guarantee. You can't say, well, we just have to keep looking until we find it, because you could look forever. Now, there are also some reasons why brain imaging isn't diagnostic that have to do with the way current psychiatric diagnosis works, that is, current psychiatric nosology. The DSM is designed for validity and reliability. Okay, validity means, roughly speaking, the degree to which these categories in the diagnostic system really map onto true categorical differences in reality. So like the idea is that reality is lumpy. Okay, there are certain clusters of problems that go together, clusters of symptoms and signs that go together in reality, and a diagnostic system of categories is valid insofar as it labels those with its labels. A system is reliable to the extent that different diagnosticians using that system arrive at the same diagnosis for a given patient. Well, DSM-3 was really kind of hailed as a great breakthrough in reliability. I mean, that was the good thing about it. How reliable it is, I don't know. I think, there's debate. Depends whose diagnoses you're looking at to see how reliably they use the system and so forth. But, I think people recognize that a big goal for the DSM was to come up with a reliable system of categories, and I think most people are willing to give it some credit on that score. But in terms of validity, nobody really thinks these are valid categories. I mean, even if we had the heads of the committees that wrote the latest edition of the DSM here, and we said to them, do you think these categories really describe the structure of reality? Are these categories ground truth? They would say, no, probably not. They're kind of taking the previous categories that we had, which we weren't deluding ourselves were ground truth, and they're tweaking them a bit to try to get a little closer to what seems like the truth. But people are pretty agnostic about these categories. People, the people who use them understand that they represent a sort of compromise among many different scientific and social demands that are put on this diagnostic system, scientific, social, and historic demands, because you don't want to totally radically swap out your diagnostic system from one year to the next, right? There are reasons that a certain amount of conservatism in the system is valuable. If all of our previous research knowledge about what kinds of patients benefit from what kinds of treatments has been encoded in one system of categories for identifying which patient has what disorder, then to be able to kind of continue making use of that knowledge, building on it, you don't want to just wholesale throw it out and start from scratch. Steve Hyman has described the process of revising the DSM as kind of like trying to rebuild an airplane while you're flying it. Okay, and I think that captures very nicely, the need for continuity and conservatism that limits how much we can try to improve it. Now, we assume that valid categories would align with imaging, that imaging does pick out what you might call natural kinds. But unfortunately, we are all too aware that the categories we have, again, better reliability than validity. There is a development coming out of NiMH that may be the bridge that we need to get from here to there, to get from this system of categories that at some level we don't have any confidence in, or we don't have much confidence in, but we feel like we need for practical purposes, and the future where psychiatry will be based on diagnoses that are neurologically real. And that possible bridge is called RDoc, which stands for Research Domain Criteria. This is a set of what are called domains by Tom Insel, director of NiMH, that describe kind of parts of the human mind and brain, components of the human mind and brain that seem to have a neurological reality, seem to correspond to dimensions of individual difference, that is, ways in which people differ from one another, that map onto patterns of genetic difference. And what he is suggesting, he's more than suggesting, what he is rather firmly twisting researchers' arms to do at this point, if they want to get funded in their research by NiMH, is to describe their patients in terms of RDoc, or in terms of some system like that. In other words, a system like negative affect, which is going to involve the amygdala. And we know certain things about the relation between negative affect and the amygdala. We have certain experimental tasks that they think pretty reliably elicit this role of the amygdala and negative affect and so forth. And so the idea is that we kind of have like one foot in each world. We are kind of keeping track of what the DSM diagnoses of our patients are, but we are selecting them, targeting our interventions to them, and so forth, based on how RDoc classifies them. In other words, these two patients, they might have different diagnoses in DSM, but they both share this elevated negative affect dimension. Now you can ask, how do we know these are the right dimensions? Are these valid? I think the answer is time will tell. There's certain, as an aside, let me say, there are certain questions that are empirical questions, but they're not the kind of questions that you can settle with a critical experiment. Okay? They're not single experiment questions. They're questions that, over the course of many years, many different people in many labs working, laboring away, the answer to this question will become clear. So, right now, the field is to a certain extent putting its bets on RDoc. It's an empirical question whether RDoc captures the most fruitful, relevant dimensions of variation. And we'll know, in I don't know how many years, maybe 10, maybe 20, whether this is a fruitful way to sort of make our divisions among patients and treatments and so forth. Okay, so let me just close with this question. Is there reason for optimism? Well, I think there is, actually. There is tremendously rapid progress in the development of brain imaging, both at the level of physics, the actual acquisition of images, also at the level of statistics, ways of analyzing that data to infer things. In fact, it's really quite amazing to me how much rapid progress there has been, and even how many pretty promising looking small-scale studies have used these pattern classifiers to distinguish among, you know, multiple different psychiatric disorders. So, you know, we may be closer than we think to the day when we will be able to use brain imaging as an adjunct to diagnosis. You know, I don't think anybody, even the Amen people, would say it's the only thing you would use. I think also reason for optimism is the increased flexibility concerning alternatives to DSM categories for research. You know, I think sort of having one foot in each camp is probably the most productive thing we can do now. Not forget about DSM, but be thinking very seriously about these other approaches. But let me just say that this is going to take the accumulated results of many well-designed studies. And unfortunately, despite the, you know, fairly long-standing, I mean, I would say at least 10 years, that the people who I quoted at the very beginning, you know, sort of Daniel Amen and his colleagues who run similar kinds of clinics on the one hand, kind of more establishment psychiatry researchers and practitioners on the other hand, despite the fact that they've been, you know, sort of arguing back and forth for a while, there hasn't been any useful research produced directly relevant to that debate. Now, it seems to me that the burden is on the people who say, look, we can do this with brain imaging to produce the data. And they really have not. They point to how many scans they've done. And I don't know if we're supposed to feel better about that. I mean, it seems like you could feel worse. My God, they're doing this over and over again, and we don't have proof that it works, right? There are a few research studies out there. They would not be accepted in, you know, reasonable peer-reviewed journals. The more serious publications trying to show the efficacy of SPECT have used SPECT in the diagnostic process for psychiatric patients, but they've basically just shown, well, actually, it's not depression, or it's not ADHD. The person has a brain tumor, or the person, you know, was poisoned by breathing, you know, solvents at work for years and years. And of course, that use of brain imaging in psychiatry has long been recognized. You know, you rule out medical causes for the disorder, but the idea that you can use these SPECT scans or any other kind of brain imaging right now to diagnose or distinguish among primary psychiatric disorders just has no database to turn to. So really we need a literature there, a good size one, because it's not something that you run out and do one experiment and say, yes, you know, the light bent, you know, exactly the way my theory of relativity said it would around Mercury, you know. It's not the kind of thing that lends itself to a critical experiment. It's going to take accumulating research and you know, and a certain amount of, I think you could sort of call it adversarial cooperation, collaboration. The two sides need to have a serious discussion, share their thoughts about what would constitute reasonable evidence, and then get to work collecting it. So I'm going to stop there and ask you for questions.